We are looking at a set of data today that, honestly, it makes you wonder how the human race is even functioning.
It's pretty staggering when you see it all laid out.
We are talking about the single most common blood disorder in the world. But, calling it a disorder feels like it's underselling it.
I agree completely. It's not just a disorder. When you look at the World Health Organization numbers we have here, it looks more like a global biological failure, a massive silent burden on human health.
A silent burden. That's a good way to put it. Let's look at those raw numbers for a second, because usually when we talk about an epidemic, we're talking about what? A fraction of a percent of the population.
Maybe a few million people, sure. That's what gets headlines.
Exactly. But according to this WHO data, we are looking at 4 to 5 billion people who are iron deficient.
4 to 5 billion, with a B.
That's what? Somewhere between 66 and 80% of the entire world's population. Basically, half the planet is running on low iron.
Right, and that's just the deficiency part. Within that massive group, you have about 1.62 billion people who have crossed the clinical line into being fully anemic.
A quarter of the global population.
Quarter of the world. It's a scale that's difficult to grasp.
It is. If this were a virus or some new flu strain, every news channel would be running 24-hour coverage. But because it's anemia, it just gets filed under, I'm tired.
And that's exactly the problem. It is so often dismissed as just a symptom of modern life. People say, oh, I'm stressed or I'm working too hard, I just need a vacation.
Right.
But our goal for this deep dive is to completely dismantle that I'm just tired mindset.
Yeah.
We want to look at anemia for what it actually is, a mechanical failure in the body's most critical supply chain.
Okay, that's the shift we want to make. This isn't just about fatigue. We're talking about a fundamental breakdown in oxygen delivery. So let's start right there with the core definition. When a doctor says anemia, they aren't being vague. It's a math problem, right?
It's strictly math. Anemia is defined as a decrease in hemoglobin, or HB, or the number of red blood cells. The end result is a failure of the blood's oxygen carrying capacity.
And there are hard clinical lines in the sand for this.
Very hard lines. For men, if your hemoglobin is below 13 grams per deciliter, you're clinically anemic. For women, that cutoff is a little lower. It's 12 grams per deciliter.
13 for men, 12 for women. Simple as that.
Correct. And what that means biologically is that your tissues are, in a very real sense, slowly suffocating. But here's the nuance that I think people miss. Anemia is rarely a disease in isolation.
Okay.
It's almost always what I call a smoke signal.
A smoke signal. What do you mean?
It's a sign that something else is burning. It tells you there's an underlying pathology. Maybe it's nutritional, maybe it's a genetic issue, or maybe, and this is critical, maybe it's malignancy. The anemia is just the red flag waving to get your attention.
This is a perfect setup to pop the hood and look at the engine here. Let's get into the biology of this. Part 1 of our outline, the breakdown. Before we talk about why the system fails, how is it supposed to work? The source material uses the term hematopoiesis.
Hematopoiesis. It's a mouthful, but it's a simple concept. It's the factory floor.
Okay.
It's the formation and maturation of all blood cells happening inside the bone marrow. And specifically for our topic, we're looking at a single process within that called erythropoiesis.
And that's the assembly line for red blood cells.
Precisely. That's the part of the factory that makes the red cell.
And this assembly line is vital for more than just, giving you energy, right?
Oh, absolutely. This process is central to hemostasis, which is your body's ability to form clots and stop bleeding. It's central to your immune system and, of course, oxygen delivery. Your bone marrow is a 247 factory. It never, ever shuts down.
So when you see anemia, it means that factory has been disrupted in a major way.
The whole system crashes, or at least it sputters.
I found this really helpful. The sources categorize the causes of anemia into 3 main buckets. If you are anemic, it's because of one of these 3 mechanisms. Let's walk through bucket number 1.
So bucket 1 is inadequate production. It's the simplest one to understand. The factory simply isn't making enough cars.
And why would that happen?
It could be for 2 reasons. 1, you're missing the raw materials. That would be things like iron, vitamin B12, or folate. Or 2, the machinery itself, the bone marrow, is damaged or failing.
Okay, so a supply chain shortage or a broken factory. That makes sense. What's bucket number 2?
Bucket number 2 is increased destruction. Clinically, we call this hemolysis.
Hemolysis.
In this scenario, the factory is pumping out cars just fine, the production line is working, but as soon as those cars roll off the line, something is out there smashing them.
And what would be smashing them?
This happens in certain autoimmune diseases where your own body attacks your red blood cells, or in genetic conditions like sickle cell anemia where the cells are fragile and break apart easily.
Got it. And that brings us to bucket 3.
Bucket 3 is just blood loss. The factory's fine, the cars themselves are fine, but you've left the garage door open and they're all driving away.
This is just bleeding.
Exactly. And it can be obvious, like from a major trauma, or it can be insidious and almost invisible, like a slow, chronic GI bleed that you don't even know you have.
So when you view it through those 3 buckets, production, destruction, or loss, it completely changes the detective work, doesn't it? You aren't just treating low blood.
You can't. You have to find out if you're leaking, if your cells are broken, or if your factory's undersupplied.
And this is why I'm guessing anemia is such a massive comorbidity in other major diseases. The data here is pretty stark.
It really is. The source notes that anemia prevalence in cancer patients can range from 30% all the way up to 90%.
90%, wow.
And it's inextricably linked to things like HIV, malaria, heart failure, and especially chronic kidney disease. It's the canary in the coal mine.
How so? With kidney disease, for instance.
Well, the kidneys produce a hormone called erythropoietin, or EPO. That hormone is the signal that tells the bone marrow to make red blood cells. So if your kidneys fail, they stop sending the signal. The factory just sits there, idle, waiting for an order that never comes.
The phone line to the factory is cut.
Exactly. Or if a malignancy takes hold, it acts like a parasite. It starts stealing all the resources, the iron, the vitamins, to feed itself. So if you find anemia, you are, as a clinician, obligated to ask why.
Let's move to that. Part 2, the detective work. Because the why often starts with what the patient is actually feeling. The sources make a big distinction between acute and chronic anemia. Why does the speed of onset matter so much?
Oh, it matters immensely because the human body is incredibly adaptive. If you have acute anemia, say, from massive blood loss in a car accident, your body has 0 time to adjust.
A sudden shock to the system.
A huge shock. You crash and you crash hard. You get tachycardia, which is a racing heart. You feel lightheaded, you're breathless. Your blood pressure just plummets because the volume is gone.
But chronic anemia is a different beast entirely. This is the slow burn.
Exactly. If you lose blood a teaspoon at a time over 6 months, or if your production slowly fades over a year, your body compensates. It's clever. It adjusts the plasma volume in your blood. It changes how the heart pumps to be more efficient.
So you might not feel sick in that dramatic, acute way.
Not at all. Instead, you get this dragging, profound fatigue that you can't shake. You get persistent headaches. You find you're always cold, even when others are comfortable.
And you get pale.
You get pale, yes, pallor. But it's insidious. It happens so slowly that you might not notice it yourself until you look back at photos from a year ago and think, wow, I look so much healthier then.
Now, speaking of symptoms, we have to talk about the weird ones. This part of the source material was fascinating. The behavioral symptoms of iron deficiency anemia, or IDA, sound like they belong in a psychology textbook. I'm looking at pica.
Pica is one of the most bizarre and interesting clinical signs. It is the craving and the compulsive eating of non-food items. We see patients eating dirt, clay, chalk, even laundry starch.
And then there's a specific subset of this, pagophagia.
Pagophagia. That's the one that's a huge red flag for iron deficiency. It is a specific, intense craving to chew ice.
I know people who do this. They'll go to a restaurant and just crunch through their entire cup of ice. I always just thought it was a nervous habit.
It can be, but more often than not, it's a biological scream for iron.
Do we know why? What is the connection between chewing ice and needing iron?
We don't fully understand the mechanism, but one leading theory is that the coldness in the act of chewing triggers a reflex in the brain that increases blood flow to the head. It's called the mammalian diving reflex.
So it's like a temporary cognitive boost.
A very temporary one, yes. It might be the body's way of momentarily waking up a sluggish, oxygen-deprived brain. But if someone tells you they are addicted to chewing ice, you check their iron immediately. No questions asked.
That is a wild connection. What about the physical changes you can see? The sources mention glossitis.
Yes, this is a painful, smooth, sometimes beefy red tongue. The papillae, those little bumps that give your tongue its texture and house your taste buds, they actually atrophy and disappear.
They just flatten out.
They flatten out completely. They need a constant supply of iron to regenerate, and without it, they can't. You also often see something called angular cheilitis, which are painful cracks at the corners of the mouth.
Okay, now let's contrast that with the symptoms for megaloblastic anemia. That's the B12 or folate issue.
Mm-hmm.
That presents totally differently.
Very, very differently. With B12 deficiency, the biggest red flags are neurological.
Or neurological.
Yes. Numbness, paresthesias, that classic pins and needles sensation, especially in the hands and feet. You also see psychiatric symptoms, irritability, memory loss, even severe depression.
And physically.
You might see icterus, which is a mild jaundice or yellowing of the skin and eyes. And there can be gastric mucosal atrophy, which affects the stomach lining.
So if a patient comes in feeling depressed, irritable, and their feet are tingling, it's easy to see how that could be misdiagnosed as just a mental health issue, or maybe diabetes causing the neuropathy.
It happens all the time, which is why the physical exam is so critical. We have to look for the visual clues, the things the patient might not even notice.
Okay, walk us through that exam. If I'm the anemic patient, what are you looking for? Where do you start?
I'm probably starting by looking at your hands, your nail beds.
The nails.
Yes. In a healthy person, the nail bed is pink. In anemia, it's pale. The nails might also be very brittle, or in severe, long-standing iron deficiency, they can become spoon-shaped. It's called koilonychia.
Spoon-shaped nails. Okay, what's next?
Then I'd check for orthostatic hypotension.
That's the standing up and getting dizzy test, right?
That's the one. We measure your blood pressure while you're lying down and then again right after you stand up. If your blood pressure drops significantly, it suggests your volume depleted. You just don't have enough blood in the tank to fight gravity when you change position.
And finally, the most classic sign.
The conjunctiva.
The inside of the eyelid.
Exactly. I'd ask you to look up, and I'd gently pull down your lower eyelid. In a healthy person, that tissue should be a rich, meaty red. If it's pale pink or almost white, that is a very strong indicator that your hemoglobin is low. It's a remarkably accurate bedside test.
So we've chewed the ice, we've checked the eyelids, now we draw the blood. This brings us to part 3, decoding the labs. This is where it can get technical, but the source material offers a really clear way to break this down using what it calls morphologic classification.
This is the decoder ring for any doctor looking at a blood count. It all revolves around one single value on the report, the MCV.
MCV, and that stands for mean corpuscular volume.
Which is just a very fancy way of saying how big is the average red blood cell.
And the size tells you the cause.
It narrows it down significantly. It's the first branch in the decision tree. We sort anemias into 3 bins based on cell size. Bin number 1 is microcytic.
Micro, meaning small.
Exactly. The MCV is less than 80. The cells are tiny. This pattern almost always points to iron deficiency. Without enough iron to build hemoglobin, the cell can't fill up to its normal size, so it stays small.
Okay, so small cells equal an iron problem. What's bin 2?
Bin 2 is normocytic, normal size. The MCV is right in the sweet spot between 80 and 100.
So the cells look fine.
The individual cells look perfectly fine, there just aren't enough of them. This is the tricky one. It's usually caused by anemia of chronic disease, which we'll get to in a bit, or by acute blood loss.
And that leaves bin 3, macrocytic.
Macro, meaning large. The cells are huge. The MCV is greater than 100. They look bloated and oversized. This points us directly to a problem with DNA synthesis.
DNA synthesis.
Yes, the cell is trying to divide, but it can't replicate its DNA properly, so it just gets stuck in the growth phase. It just keeps getting bigger and bigger. This is the hallmark of vitamin B12 or folate deficiency.
Okay, so that's a great heuristic. Small is iron, normal is chronic disease or bleeding, big is B12 or folate.
That's the core of it. And you can layer one more piece of information on top of that. The color.
Right, the source calls this chromic.
Yes. Hypochromic means low color. The cells look pale under the microscope because they don't have enough hemoglobin. Normochromic is a normal, healthy red. So putting it all together, the classic picture of iron deficiency is microcytic, small, and hypochromic, pale. They look like little ghost cells.
This is a great framework. Let's use it to dive deep into the specific types now. Part 4. We have to start with the global leader, the most common type by far, iron deficiency anemia, IDA. We know the cells are small and pale, but the iron studies, the specific lab tests, are a bit more complex. You can't just measure the iron floating in the blood, can you?
No, you can't. The serum iron level fluctuates wildly based on what you ate for breakfast. It's not a reliable marker. To get a real, accurate picture of someone's iron status, we need to look at 3 distinct metrics: ferritin, transferrin saturation, and TIBC.
Okay, let's define those. Let's start with ferritin.
Ferritin is your iron storage tank. Think of it as the iron you have locked away in the bank vault, in your liver, your spleen, your bone marrow. In IDEA, your ferritin is LOW. In fact, this is the earliest and most sensitive indicator.
It drops before you even become anemic.
Yes, your body is smart. Before it lets the circulating hemoglobin drop, it drains the savings account first. So a low ferritin tells you the stores are empty, even if the anemia hasn't fully set in yet.
Okay, so ferritin is the storage tank. What about transferrin saturation?
If ferritin is the bank, then transferrin is the armored truck that carries the iron through your bloodstream to the factory. Transferrin saturation tells us what percentage of those trucks are actually carrying iron. In IDA, the saturation is LOW. The trucks are driving around empty.
Which brings us to the last one, TIBC, total iron binding capacity. This one is a little counterintuitive because in ID this number goes HIGH. Explain that relationship.
I like to think of TIBC as the number of empty parking spots available for the armored trucks. If you have very little iron, very few trucks on the road, you have a lot of empty parking spots. Your body is desperate to grab any iron molecule it can find, so it ramps up production of transferrin, creating more and more empty spots. It increases the capacity.
So the body is screaming for supply by making more docking stations available.
Precisely. So the classic IDA pattern is low storage, ferritin, empty trucks, low saturation, and high capacity. Or lots of empty parking spots, high TIBC.
That makes perfect sense. So once you have that diagnosis, how do we fix it? The source material really emphasizes that the goal isn't just to fix the anemia, it's to refill that storage tank.
That is the most critical part of treatment. You can fix the hemoglobin number relatively fast, but if you don't replenish the ferritin, the patient will just relapse. The gold standard for treatment is oral iron. Usually we aim for 150 to 200 milligrams of elemental iron per day.
But here is where we hit what the source calls the food rules, because apparently iron is incredibly high maintenance when it comes to absorption.
It's a total diva. Iron is best absorbed from what we call heme sources. That's the iron found in meat, fish, and poultry. It is very poorly absorbed from non-heme sources like vegetables, grains, dairy, and eggs.
Which is bad news for vegetarians and vegans.
It makes it much, much harder for them to maintain their iron levels, yes. And then there's the rule that tripped everyone up. Taking your iron supplement with a meal reduces its absorption by up to 50%.
50%. So you're essentially wasting half the pill if you take it with your morning toast and coffee.
Exactly. And certain things are major blockers. Calcium from dairy products, polyphenols in tea, phytates in grains. Washing your iron pill down with a coffee or a glass of milk is essentially neutralizing it.
So ideally, you have to take it on an empty stomach. But the notes also say that iron is notorious for causing stomach issues.
And that's the catch-22 of iron therapy. Iron on an empty stomach is absorbed best, but it causes nausea, cramping, constipation, and stomach pain. It can be really brutal for some people.
So what's the practical advice?
Realistically, we often tell patients to try it on an empty stomach first. If they can't tolerate it, then take it with a little bit of food. And specifically, taking it with vitamin C, like a small glass of orange juice, can actually enhance absorption and buffer some of the GI upset. At the end of the day, it's better to absorb 50% of the pill than to stop taking it entirely because of the side effects.
That makes sense. What if oral iron just fails? Or if the patient has a malabsorption issue like celiac disease or has had gastric bypass surgery?
In those cases, we have to bypass the gut entirely. That's when we turn to parenteral or 5E iron.
And the source material has a specific safety warning here, particularly regarding a formulation called iron dextrin.
Yes. This is very important. The older formulation, iron dextrin, carries a black box warning from the FDA for anaphylaxis. It can cause a massive, sudden, and life-threatening allergic reaction.
That sounds terrifying.
It is, and it means you have to give a small test dose and monitor the patient very closely. But thankfully, the newer formulations, things like iron sucrose or sodium ferric gluconate, have a much, much lower risk profile. They're significantly safer and have become the standard of care for IV iron.
Let's talk about the timeline for recovery. If I start taking iron today, when do I start to feel better? When am I fixed?
It's definitely not overnight. The first thing we look for happens in about 5 to 7 days. We should see a spike in reticulocytes.
And those are the baby red blood cells, right?
Exactly. They are the brand new cells rolling off the factory line. A spike in reticulocytes tells us the factory has the raw materials and has restarted production. That's our first sign that the treatment is working.
And the hemoglobin number itself.
The hemoglobin should rise about 2 to 4 grams per deciliter every 3 weeks. But, and this is the part people forget, you must continue the treatment for 3 to 6 months after your hemoglobin normalizes.
To fill the tank.
You have to fill the tank.
Yeah.
If you stop as soon as you feel better, your ferritin stores are still empty, and you'll be right back where you started in a few months.
All right, that's a great deep dive into IDA. Let's pivot now to the second major type, megaloblastic anemia, the big cells.
The big cells. MCV is high, usually over 110, sometimes up to 140. And if you look at the blood smear under a microscope, you see these giant, oval-shaped red cells. And critically, you see hypersegmented neutrophils.
Hypersegmented neutrophil, break that down.
It just means that a type of white blood cell, the neutrophil, has a nucleus with too many lobes or segments. It's another sign of that DNA synthesis failure we talked about. The cell is trying to mature and divide, but it can't, so its nucleus just gets all bunched up and weird looking.
Now, the most critical distinction here is between the two causes, vitamin B12 deficiency and folate deficiency. They both make big cells. Why is it so incredibly important to know which one it is?
This is one of the most dangerous and classic traps in all of hematology. It's something that is drilled into every medical student. Both deficiencies cause the exact same megaloblastic anemia, but only B12 deficiency causes neurological damage.
And what kind of damage are we talking about?
It's called subacute combined degeneration. It's a demyelination of the spinal cord. It leads to that numbness and tingling, loss of balance, and eventually, if untreated, can lead to irreversible paralysis and dementia.
And the source material has a warning here in bold text. The danger of masking.
Yes,
Yeah.
this is the trap. If you have a patient who is actually B12 deficient and you mistakenly give them high doses of folate, you will fix the blood number.
Anemia goes away.
The anemia completely resolves, the MCV comes down, the hemoglobin comes up, the blood count looks perfect, but you have done absolutely nothing to stop the progression of the neurological damage.
So the doctor looks at the lab report and thinks, great, the patient is cured, while the patient is actually slowly losing function in their nervous system.
Exactly. You've masked the smoke signal while the fire continues to burn down the house. That is why you must check both B12 and folate levels before you ever start treatment for a macrocytic anemia. You cannot guess.
And when it comes to treating B12 deficiency, is it always injections? I feel like that's the common perception.
Historically, yes, we thought you needed shots for everything, especially for a condition called pernicious anemia, where the stomach lacks a factor needed to absorb B12. But recent data has shown that very high-dose oral B12, we're talking 1,000 to 2,000 micrograms, can actually be just as effective.
How does that work if the stomach can't absorb it?
Because about 1% of any oral dose gets absorbed through passive diffusion, bypassing the normal mechanism. So if you give a massive dose, that tiny 1% is enough to correct the deficiency. However,
There's a but.
there is. If a patient presents with any of those neurological symptoms, the tingling, the balance issues, the memory problems, we don't take chances. We start with parenteral therapy, with injections, to get the levels up as quickly and reliably as possible.
Okay, that makes sense. Now for the third type. And this one, I have to say, I found the most intellectually fascinating. Anemia of chronic disease, ACD.
It's a really interesting one, and it's also the most common type of anemia you'll see in hospitalized patients. You find it in the elderly or in anyone with a chronic infection like HIV or tuberculosis, a chronic inflammatory state like rheumatoid arthritis or malignancy.
The mechanism here is completely different from the others. It's not that you don't have iron, it's that your body is deliberately hiding it from you.
That is the perfect way to describe it. It is an iron utilization problem, not an iron deficiency problem. And the lab pattern looks very strange at first. Serum iron is low, but ferritin, the storage tank, is normal or even high.
So the bank vault is full, but the armored trucks are all empty. Why would the body do that?
It's an ancient evolutionary defense strategy that we call iron trapping.
Iron trap?
Yes. Think about it. What do invaders need to grow and multiply? Things like bacteria, viruses, and even cancer cells. They all require iron to replicate. They thrive on it. So when your body senses a major threat, a state of high inflammation, it sounds the alarm.
And what happens then?
The liver releases a key hormone called hepcidin. Hepcidin is the master regulator of iron. And when its levels go up, it acts like a jailer. It goes to the cells that store iron and it locks the doors. It refuses to release any iron into the bloodstream.
It's a scorched earth policy inside your own body. You're willing to starve the bacteria, even if it means you also starve your own bone marrow factory of its key raw material.
Precisely. Your body makes a calculated decision that being moderately anemic is safer than feeding a potentially lethal infection or a growing tumor.
That recontextualizes everything. It's not a failure of the system, it's a feature. So if you give this patient iron pills,
You are fighting against your body's own defense strategy. And you might even be making things worse by providing fuel for the fire. That's why iron therapy is generally not effective and potentially even harmful in true anemia of chronic disease.
The iron just gets locked away immediately.
It gets trapped in storage instantly, or worse, the bacteria or tumor cells might grab it before it even gets there.
So how on earth do you treat it?
You don't treat the anemia, you can't. You have to treat the underlying disease. You give the antibiotics for the infection, you manage the autoimmune flare, you treat the cancer. Once the inflammation subsides, hepcidin levels drop, the jailer unlocks the doors, and the iron flows freely again.
That is such a critical and counterintuitive nuance.
Yeah.
Let's see how this all plays out in the real world. I have 2 case studies in the notes that are really illustrative. Let's look at case 1, patient DG.
Okay, so DG is a 35-year-old woman. She comes in presenting with weakness, dizziness, and she reports a history of heavy menstrual bleeding. She also mentions she takes ibuprofen frequently for headaches.
And that's a clue, right? NSAIDs like ibuprofen can cause stomach irritation and low-level bleeding, so she might be losing blood from both ends, so to speak.
It's a definite possibility. So her labs come back. Her hemoglobin is 8 GDL, significantly low. Her MCV is 75, so they're small cells.
Microcytic.
Exactly. Her ferritin is 9 ng/ml. The tank is basically empty. And her TIBC is 450 millicGDL, which is very high.
High capacity. The body is desperate. This is the absolute textbook definition of iron deficiency anemia.
It is a slam dunk diagnosis. So the plan is straightforward. Start her on ferrous sulfate, 325 milligrams 3 times a day on an empty stomach.
But the case study notes a real-world challenge. She comes back for a follow-up a month later, and while she is feeling better, she admits she misses doses all the time.
And this is the reality of treating IDEA. Telling a busy 35-year-old to take a pill that might upset her stomach 3 times a day away from meals. It's a hard regimen to stick to. She has a life, she forgets. Or it hurts her stomach, so she skips it.
But her numbers still improved.
They did. Even with the missed doses, her hemoglobin rose to 10 GDL, which is a great response. Her symptoms were much better, but it just highlights that compliance is the single biggest hurdle in treatment. We have to work with the patient. Maybe we switch to an every other day dosing schedule, which some new studies suggest is just as effective and much better tolerated.
Okay, now let's look at case 2, patient CM. This is a totally different profile.
Completely different. CM is a 60-year-old man. He has a 1-year history of progressive weakness. He's been emotionally labile. He has a painful tongue. And this is the key tingling in his feet.
The tingling, the paresthesia, that's the neurological red flag.
That's the one. His labs show a hemoglobin of 9, so he's anemic. But his MCV is 110, macrocytic.
So you have the equation, big cells plus neuropathy.
And that equation almost always equals vitamin B12 deficiency. If this were just a folate deficiency, he likely wouldn't have the tingling feet. The treatment here needs to be aggressive, likely starting with B12 injections, because our primary goal is to stop and hopefully reverse that nerve damage before it becomes permanent.
These cases really show that you can't just treat the number on the page. You have to treat the whole person, the whole clinical picture.
You absolutely have to.
Before we wrap up, let's just touch briefly on a couple of special populations. The notes mention the elderly specifically. What's different about anemia in older adults?
Well, in the elderly, the symptoms are often very subtle and easily dismissed. We might attribute confusion, weakness, or fatigue to just getting old, but it could very well be treatable anemia. And more importantly, in an elderly person, new onset anemia, especially iron deficiency, is a massive red flag for GI malignancy. Like colon cancer, you cannot ignore it. It requires a full workup.
And for pediatrics, for kids.
With kids, you have to remember they have huge iron needs simply because their bodies and blood volume are growing so rapidly. The key is that you have to use age and sex-adjusted norms. A normal hemoglobin for a 2-year-old is very different from that of a 12-year-old. You can't just use the adult reference ranges.
And finally, a quick practical warning on adverse effects. We talked about the stomach upset from oral iron, but there is one specific harmless side effect that always freaks patients out.
The dark stools.
Yes.
Oral iron supplements will turn your stool black or a very dark green. It can look a lot like melena, which is the black tertiary stool you get from digested blood from an upper GI bleed. Patients often panic, thinking they are bleeding internally. It's totally harmless, but you have to warn them about it so they don't stop the medicine in fear.
And for the OV iron we mentioned.
The main things to watch for are hypotension, a sudden drop in blood pressure during the infusion, and allergic reactions like a rash or shortness of breath. It's why it always has to be administered in a monitored clinical setting.
We have covered a massive amount of ground here, from the factory floor of the bone marrow all the way to the iron trap of chronic disease.
It's a complex and beautiful system when it's working.
It really is. If the listener takes just one single thing away from this entire deep dive, what do you think it should be?
For me, it has to be the concept of the smoke signal. Anemia is almost never the primary villain of the story. It's the messenger. And whether that message is telling you that your diet is poor, your gut is leaking blood, or your body is fighting a hidden war against an infection or a cancer, you have to listen to the signal. Don't just take a pill to silence it. You have to find out why it's there.
And that iron trap concept, that idea that our bodies are smart enough to strategically starve a bacteria by hiding our own iron, that is going to stick with me. It really challenges the simple idea that symptoms are just failures of the body. Sometimes they're actually strategies.
Exactly. It forces us to respect the body's innate logic, even when that logic makes us feel terrible in the short term.
A provocative thought to end on. Respect the body's logic, check your eyelids, watch the ice chewing, and get your labs done. Thanks for joining us on this deep dive.
Stay curious.